Hello, everyone. I'm Dr. Carmen Pugliafito, and today I have with me Dr. Dilsher Dhoot from Santa Barbara, California, to discuss Pegcetacoplan 5-year results.
Hey,
Dilsher,
Carmen.
welcome back to Retina Synthesis.
Thank you. Great to be with you.
You presented this at the Macula Society, and it was really a 5-year look at the GALE data from the Apellis Syfovre trial. Why don't you frame the trial for us?
Absolutely. Oaks, Derby, and Gale are the largest open label extension and longest clinical programs in geographic atrophy. And as you know, patients with geographic atrophy secondary to age-related macular degeneration were randomized initially in Oaks and Derby, the pivotal phase 3 trials. And they were randomized in a 2-to-2, 1-to-1 fashion to pegcetacoplan monthly, pegcetacoplan every other month, or sham monthly or sham every other month. These trials are 24-month trials, and after the 24-month trials, patients were eligible to cross over into GALE, the open label extension. And GALE was planned for 36 months. And I had the pleasure of presenting for the first time at the Macula Society the data from GALE, 36-month data representing 60 months of continuous pegcetacoplan. The patients in the pegcetacoplan groups crossed over onto the same regimen as they'd previously been on in Oaks and Derby, whereas those patients in the sham groups crossed over to active treatment, but at the same interval. So meaning sham monthly went to pegcetacoplan every month, and then sham every other month went to pegcetacoplan every other month. And so that's the trial setup.
So, what were the key findings?
Yeah, first of all, the retention was fantastic. We saw, retention on par with other trials, open label trials like this, 67% retention at the end of GALE, 36 months. And if you exclude deaths, of course, this was during COVID in this elderly population, 74% retention. It's also important to point out one thing before I tell you the punchline data, which is regarding the projected sham. And so I mentioned earlier that 24 months of true sham patients, and those sham patients then crossed over to active treatment. So we no longer have a true sham from month 24 to month 60. We have a projected sham, which is based on the literature, work by Janet Sinest and others. It can predict GA growth based on 2 years of growth and subsequent 2 years being predictive of the first 2 years. And then we also have validation through the fellow eye analyses. And it's really interesting when you plot out these fellow eyes, the rate of growth was 1.92 millimeters squared per year. And the rate of growth in the projected sham was 1.98 millimeters squared per year. So this is very, very similar. So I think having a robust projected sham is very important. As far as the results, this population of patients included both subfoveal and non-subfoveal patients. And so if we look at the entire population, we saw in the first 24 months, 19 and 18% reduction compared to sham. The subsequent 36 months of GALE, the numbers increased to 27 and 26% reduction in the monthly and every other month group compared to the projected sham, yielding 24 and 23% reduction overall over the course of 60 months. If we focus on strictly the non-subfoveal patients, as we know, those lesions tend to grow faster, and those patients perhaps derive their greatest benefit. We saw in the first 24 months of Oaks and Derby, 27 and 24% reductions in the monthly and every other month group compared to sham. And in the subsequent 36 months, it was 33% and 30% reductions in the monthly and every other month group compared to the projected sham, yielding again overall over the course of 60 months, 31 and 27% reductions compared to the sham in the non-subfoveal patient population at 60 months.
So, what happened in the crossover group, the
So
late
that's a great,
group?
yeah. So that's a great question. So I think one of the messages we learned is that earlier pegcetacoplan treatment leads to 2 times more retinal tissue preserved. We saw that in those patients who started early with pegcetacoplan at baseline, 3.9 millimeters squared of tissue was preserved by 60 months. And those patients who crossed over at month 24, they still had benefit. It was 1.9 millimeters squared of tissue preserved. But this was about half the benefit we saw in those patients who began pegcetacoplan at the beginning.
So, this is an argument for treatment, isn't it?
I think so. I think if we treat these patients, we can certainly preserve functional tissue a greater amount. And one of the other messages that I demonstrated on the podium there was that, we're actually saving time for patients too. It was really interesting. One of the analyses I showed at 60 months, it was about a year and a half of time saved, meaning that a patient on continuous pegcetacoplan for 60 months, their mean change from baseline in GA growth was where their counterparts in the sham were 18 and a half months earlier.
Tell us a little bit about the differences between the every other month and the monthly doses in the crossover. What happened there?
Yeah, the monthly and very similar in the monthly and every other month. We saw the numbers, a few percentage points in difference in terms of the crossover, just as we saw in those patients who started on pegcetacoplan from baseline. So interestingly enough, I think that a lot of us dose at, probably a 6 to 8 week interval. And I think that the long-term data justifies the dosing, which, certainly can help mitigate safety issues too.
So, what are the this is wasn't covered in your talk, but it is an interesting topic, which is what are the risk factors? Which eyes show the greatest progression of geographic atrophy, and therefore might be the ones that you want to treat earliest?
Well, I think that non-subfoveal eyes certainly are eyes that you want to treat early on. I think multifocal lesions, one of the interesting studies that was presented by Dr. Boyer was that patients with high BMI for one reason or another seem to have a higher progression. We've known from before that patients with hyper autofluorescent patterns on fundus autofluorescence can also be at risk for progression. And so, I think that in the future it'll be great to see with AI to be able to demonstrate what the rate of growth is and to see how we are affecting that rate of growth. I think Phil Rosenthal has good data on this as well.
Yeah. So these days, what's your use of complement inhibitors in geographic atrophy? What's the profile, the profile of a typical patient?
I think a typical patient for me, I'm treating both non-subfoveal and subfoveal patients. I certainly am more enthusiastic in a non-subfoveal patient, but I think there is benefit, and we've done post-hoc analysis looking at the benefit in subfoveal patients also. I think that generally I look at the criteria for the trial and just for initiation of therapy. I think that and to be sure that the payers will align. I tend to try to fit within that criteria in terms of visual acuity, better than 2200. And so I think the perfect patient perhaps would have multifocal lesions with fundus autofluorescence, documented growth, that I can show the patient over a year or two. And that's the type of patient I'll use this drug on. And generally, I'm dosing about every other month.
So you're an every other month person. Which eye do you treat first?
I treat the worst eye first, and usually I'm doing about a half dose to make sure that they're not going to be one of the patients that has a vasculitis issue. And then I tend to move on with the better seeing eye, and potentially we'll treat both of them. One of the interesting things I brought up during the talk was actually the real world vasculitis update. And this drug has been approved since February of 2023. So now we have 3 years of data, and we can look at the total number of eyes with retinal vasculitis. And what's interesting is in 2023 it was 19 eyes, in 24 it was 11 eyes, in 2025 there were just 2 eyes that had a retinal vasculitis event. And so, for whatever reason, the rate appears to be decreasing over year. And we've seen this also within the RCA data. So some folks think that it might be underreported, but we've seen this to be consistent in the RCA data, which is less likely to be underreported there.
What about the difference between Izervay and Syfovre? Is there a difference?
I believe that there's I think most folks would agree that there's potentially an efficacy difference in terms of lesion growth, and I think that in general, the rate of vasculitis is lower with Izervay, but I think the edge is there for Syfovre in terms of the efficacy. I think we see some mitigation of this rate of vasculitis with Syfovre, which is good to see year over year now.
One of the arguments that the complement naysayers use is that where's the visual acuity benefit? How do you address that question?
My feeling about visual acuity is that this has been an evolution of learning, these GA trials, and we've seen certainly that the BCVA is not being a great measure of vision in this population. It appears to be that, from this trial and the complement factor D trial, that really it's microperimetry that might be the best way to gauge and measure vision in this population. I think trials going forward have learned from the trials of the past, and I think we'll see visual benefits simply for the fact that they understand what is the best way to measure visual function in these patients. So I think that we didn't pick the right endpoints in these trials, but in the future we will see that. But over time, certainly if you're saving tissue, it just makes sense that you'll eventually show that you're saving vision. You just have to do it for long enough in the right type of patient.
What about the patient who has uh, geographic atrophy lesion that's threatening the fovea? What about those patients?
That's a tough patient, right? I'll always counsel that patient that we're not stopping GA growth, right? And so we're just simply slowing it down. So the hope is that we're giving those patients a little bit more time than they would have had with, the natural history of their disease. But unfortunately for that patient, the inevitable is most likely for that patient that it will involve the phobia. Hopefully, our retina pipeline certainly has other therapies that'll help that patient, though.
Well, this is a great discussion. What's the next step for pegcetacoplan studies? What are they working on?
Yeah, they're working on a subcutaneous drug that's administered alongside pegcetacoplan intravitreal, and so that study is known as GALLOP. And so, we're interested to see if this will pan out also to have even additional benefit for patients.
Great. Well, Dilsher, thanks so much for your participation, and we'd love to have you back again.
Thanks, Carmen. It's always a pleasure.